we start talking about the heart. The heart doesn't rest for more than a fraction of a second at a time. During lifetime, it contracts more than 4 billion times. To support this active state, the coronary arteries supply more than 1 million liters of blood to the myocardium and more than 200 million liters to the systemic circulation. Cardiac output can vary under physiologic conditions from 3 to 30 liters per minute, and regional blood flow can vary by 200%. This wide range occurs without any loss of efficiency in the normal state. So let's talk about the major heart disease. You know that in the whole world, cardiovascular disorders, this is #1 cause of death. So if we talk about major heart disease, this is coronary heart disease or coronary artery disease. This is hypertension, arterial hypertension, diabetes, congenital heart disease. Among these disorders, important, this coronary heart disease, hypertension, as a major risk factor for development of coronary heart disease. As usual, when we start new topic, we start talking about signs or symptoms of disease. Let's talk about main symptoms of cardiac disease. So this is following signs or symptoms. First, chest pain, chest pain. Then next, palpitations, palpitations. Dyspnea, dyspnea. Syncope, syncope. Fatigue, fatigue. Dependent edema, dependent edema. And hemoptysis, hemoptysis. Some of these terms familiar for you, some terms maybe you hear the first time in your life. That's why I'll try to explain you each sign or each symptom of cardiac disease. First of all, chest pain. You know that not all kinds of chest pain due to heart disease, because in the chest we have a lot of other organs. We have lungs, pleura, aorta, esophagus. We have muscles, nerves, ribs, skin. That's why we have different coronary artery disease. It may be valvular disease, pulmonary hypertension, carditis. It may be vascular cause, for example, dissection of the aorta. It may be pulmonary cause, for example, pneumonia or pulmonary embolism or pleuritis. It may be musculoskeletal causes, arthritis, muscular spasm, neural, for example, herpes zoster may give very high intensity of pain in the chest. Maybe even gastrointestinal problems like esophagitis, ulcer disease, bowel disease. It may be even emotional, like anxiety or depression. You see that a lot of possible causes of chest pain exist. And that's why your task to differentiate and to understand that this chest pain is due to cardiac problems, because among all these disorders, of course, the most dangerous for patient, this is heart chest pain, heart chest pain. Questions. You have patient with chest pain. Again, remember our previous class, our previous lecture. I told you that we ask the same question describing all kinds of patient complaints, including pain. Now let's remind, for example, Where is the pain? So luckily the recurrent episodes of so episodic attacks of pain continuous. What is the duration of the pain? How often do you get the pain? This once per week, once per day. What do you do to make it better? What do you do to relieve the pain? What makes the pain worse? For example, breathing, lying flat, moving your arms and neck. You see, the same questions we should ask to understand what have happened. Is it chest pain due to cardiac problems or due to other problems? Other questions. How would you describe the pain? Again, burning, pressing, crushing, dull, aching, throbbing, knife-like, sharp, constricting, sticking. You see, we can give our patients opportunities to find out, to give some solutions, which kind of pain, because sometimes patient can't explain what actually he really feels. And again, I told you that, for example, burning, pressing, crushing pain actually tell us about possibility of cardiovascular problems, angina pectoris. Does the pain occur at rest, with exhaustion, after eating? So what caused the pain? When you're moving your arms with emotional strain while sleeping. Again, angina, lack of oxygen, usually caused by physical activities. When pain happens, when patient move his arms, move where muscle joints. The pain associated with shortness of breath, palpitations, nausea or vomiting, fever, coughing up blood. So you see how many questions we can ask to understand what have happened. Because again, there are different causes of chest pain. And our task, in our case, if we talk about cardiology, to understand that this pain is due to cardiovascular problems, If we talk about chest pain, of course, first of all, we should think about angina pectoris. Angina pectoris, this is true symptom of coronary heart disease, CHD, coronary heart disease. Angina is commonly the consequence of hypoxia of the myocardium resulting from an imbalance of coronary supply and myocardial demand. Now again, you studied physiology, histology, anatomy. You know about coronary arteries. You know about atherosclerotic process, which lead to formation of plaques, the cholesterol plaques or atherosclerotic plaques in arteries. And if this plaque appear in coronary artery, it leads to restriction of blood flow. And the result, we have hypoxia. Clinically, hypoxia presented as chest pain, angina pain. Angina pectoris literally means a strangling sensation, angina in the chest pectoris. That's why it's called angina. It means that patient feels his main pain somewhere retrosternally, but at the same time, left arm, left part of the neck, left part of the head also presents some kind of pain. We tell that pain move or radiate to the left. It's associated with heaviness, paresthesia, or pain in one, usually the left or both arms. So again, typical radiation to the left arm, but theoretically, it may be even both arms. It's typically provoked by exercise and it's promptly relieved by rest. So main characteristics of one of the most important characteristics of the pain, that pain appear after physical exertion. Why? Mechanism very clear. If we have some restriction, but our body working harder to provide such blood, but to work harder, it needs more oxygen, more nutrition. But narrowed coronary arteries can't provide the sufficient amount of oxygen of blood. As a result, we have hypoxia, accumulation of lactic acid in cells. As a result, it leads to appearance of such sinus pain. At rest, what happens? Again, demand decrease. Coronary arteries can provide enough oxygen and pain disappear. That's why remember, please, that for angina pectoris, very important sign that the pain happens after physical exertion, or exercises cause the pain. And relieved by rest, and the pain relieved by rest. Angina of increasing frequency or coming on at rest, or unpredictability, unprediction. We can't predict when pain appear, is called unstable angina or crescendo angina. Crescendo, musical tone, the rising, crescendo, or unstable angina. A pain of similar rest in myocardial infarction. So again, don't forget that the same type of pain may talk not only about angina, but the same may happen in myocardial infarction. And sensation is extremely important, because if it's just angina, okay, we give just nitroglycerin and that's all. But if it's myocardial infarction, we should immediately bring patient to hospital to do cardiosurgery, stenting procedure, balloon angioplastic. And that's why, again, chest pain, why it's so dangerous? Because it may be not just due to angina, but maybe due to myocardial infarction. No, and the mechanism of the pain is myocardial hypoxia, secondary to inadequate coronary blood flow. No, I told you already about this. So differentiation, how to differentiate, how to understand, is it angina pain or not angina pain? For example, location. For angina, this is retrosternal diffuse pain. Retrosternal diffuse pain. What does it mean, diffuse? Patient never feel pain like in the point. Remember, please, when you ask patient, please show me where is the pain. And if patient use his finger to show where is the pain, one finger, point pain, we can say. It's rare, it's actually low chance that this is angina. Low chance that this is angina. In case of angina, patient try to use all his palm, showing that all the pain retrosternal big part of the chest, diffuse pain. Again, not angina, the left, inframural, something left side, localized if patient can use his finger to show where the pain. In this case, probability that this is angina rather low. Radiation. Again, angina radiate to the left. Left arm, left back, left jaw. Actually, if it's radiate to the right, no, again, it's rarely happens in angina. Description. Usually, you know, again, we used these terms already. Pressing, dull, sometimes burning, squeezing, something squeeze patient's heart, press patient's heart. If the pain sharp, shooting, cutting, sometimes patient tell, I have acute pain in the chest. It's look like as a, I don't know, needle beat my heart, and then pain disappear in seconds. Again, this is not typical for the heart, for the angina pain. Intensity, actually, in angina pain, mild to severe, mild to severe, and actually, if it's not so, no, it's not angina. Duration. Angina usually minutes. So pain appear, patient have a rest, and in 5, 10, 15 minutes, pain disappear. If patient pain lasts for many hours or days, don't forget, pain lasts for hours may be presentation of myocardial infarction. It doesn't long-lasting heart pain. This is benign. We're just talking about angina and not angina. Precipitated by. So what happened to actually with this pain? Again, what caused the pain? Again, physical efforts, physical exercising, emotions, sometimes eating, sometimes even cold. Patient in winter go out to the street and actually experience pain. It also may happen actually in angina because actually cold weather, this is stress, and may cause angina attack. Non-angina, maybe respiration. For example, if pain increase on deep inspiration, no, it can't be angina. Usually this is something wrong with pleuritis or broken ribs or muscles or nerves. Some posture cause the pain. Motion, so patient move his arm and experience pain. No, this is also can be angina. Relieved by angina, rest or nitroglycerin. Rest or nitroglycerin. Nitroglycerin, this is specific remedy. Non-angina, non-specific. So, for example, actually, in case of pleuritic pain, pain decrease when patient lie on affected side or don't move. So it depends. That's why. Remember previous questions. Differentiate, is it angina pain or not? Characteristics essential for angina pain. First lecture, I told you about Levine's sign. Commonly, patient may describe the angina clenching the fist and placing it over the sternum. It's pathognomic sign, Levine's sign. Again, you ask your patient, show me where is the pain. And what patient do? Clench his fist and place on the middle of the chest, on the middle of the chest. This is Levine's sign. If patient do this, 99% chance that this is angina pectoris, true angina pectoris. Okay, next sign. Next sign we describe as palpitations. Palpitations. Palpitations are the uncomfortable sensations in the chest associated with a range of arrhythmias. Patient may describe palpitations as fluttering, skipped beats, pounding, jumping, stopping, irregularity. No, the normal heartbeats is sensed when the patient is anxious, excited, exercising, or lying on the left side. Again, I told you that usually when everything okay, we don't feel our inner organs. If we start feeling our inner organs, something wrong. Our inner organs send signals, problems. But everyone can experience palpitations. Try to run fast, and you can feel your heart beat in your chest. Your heart in the chest, and this is also palpitations. This sensation we can say that this is palpitation. That is a logical palpitation, physiological due to. But patients with cardiovascular, they may experience such sensations even at rest, or this palpitation may happen suddenly and then suddenly disappear. So the main difference that it's happened without physical exercising, or it's happened in very low physical activity. The patient just walk on the street and experience severe palpitations. It also shouldn't be. Also, as palpitations, we describe different arrhythmias. What does it mean? Sometimes patients feel that his heart stops and then start working again. So sensations of stop of heart activity or skipped beats. Again, we don't, if our rhythm is regular, we feel nothing. But if our rhythm becomes, or heart contractions become irregular, our heart sends signals to nerve system, something wrong. And actually, patient may feel this as a skipping beats, as a stopping, as irregularity in heart activity. Also, we describe this using term palpitations, The most common arrhythmias felt as palpitations are premature ectopic beats and paroxysmal tachycardias. Late paroxysmal tachycardia. This is when heart start contracting very and rhythm may be up to 150, 180 beats per minute. Just imagine, usually at rest we have 60, 70 beats per minute. And in case of attack of paroxysmal tachycardia, patient experience 160, 170 beats per minute. It's called paroxysmal, like attacks of tachycardia. It usually starts suddenly without visible reasons and then stop abruptly or suddenly, also without visible reasons. So, if patient complain of such attacks, determine whether the patient has had similar episodes and what was done to extinguish them. Palpitations are common and don't necessarily indicate serious heart disease. Any condition in which there is an increased stroke volume, as in aortic regurgitation, may be associated with sensation of forceful contraction. So again, not in all cases palpitation tells about severe disorder. No, patient may be anxious, the patient may be excited, and in this case also sometimes we feel palpitations. But in some cases it may tell you about cardiac problems. That's why again you should ask a lot of questions to understand, is it benign palpitation or is it a result of some serious heart disease? What questions you can ask? Now again, how long have you had palpitations? Do you have current? Do they occur? When did the current attack begin? How long did it last? What did it like? Did any maneuvers or positions stop it? Because you know, in some cases, in case of paroxysmal tachycardia, for example, even taking of cold water can stop this attack. Why? No, I'll explain later. That's why when we talk about maneuvers or positions, this is what patients try to do to stop this attack. Did it stop abruptly, suddenly, abruptly? Again, this is essential for attacks of tachycardia, paroxysmal tachycardia. Could you count your pulse during the attack? Sometimes, actually, heart rate is so high that actually patients even can't count his heartbeats if he try. Can you tap out on the table what the rhythm was like? Strange question, huh? Because know-how, usually we actually can tape our heartbeats. Usually, if it's a regular beat, we can beat something like this. But if it's irregular, the patient try to show you what happened with his heart. Have you noticed palpitation of exhaustion while I told you that if you lie on your left side, some people experience feeling of palpitation. They start feeling their heart, and that's normal. During the palpitations, have you fainted, have chest pain? Very important question, because sometimes actually heart rate is so high that heart work becomes inefficient. Meaning what? That, you know, we have systole and diastole. In diastole, we have feeling of heart. Systole, this is ejection. Diastole feeling, systole ejection. But if heart rate becomes so fast, for example, 180, 200 beats per minute, what may happen? No time for feeling, no time for feeling of the heart. And that's why nothing to eject. That's why in very high heart rate, may happen that cardiac output decrease. Brain can't get oxygen with blood and patient may faint. There is an associated flush, headache, sweating associated with palpitations. Again, this tells us about problems with circulation. Palpitations which lead to problems with circulation, cardiac circulation. This is a very serious condition. No, actually, in addition to primary cardiovascular causes, palpitations may happen in case of thyrotoxicosis, hyperglycemia, low sugar level, fever, anemia, fear of suprarenal anxiety states also associated with palpitations. If you are excited, or if you know, this is possible causes of palpitation. Not only cardiovascular problems lead to palpitations. We should differentiate. We should understand what caused this sign. Okay, next, very important and very common sign. This is dyspnea. Dyspnea, or shortness of breath. Sometimes we tell dyspnea or shortness of breath. Dyspnea is an abnormal awareness of breathlessness and can be due to cardiac or respiratory cause. Patients report that they have shortness of breath or they can't get enough air, and it occurs on exertion or maybe present at rest. Again, how to understand what is a dyspnea? I may say that everyone experiences dyspnea. Again, just try to run very fast. And sooner or later, you start feeling dyspnea. You're feeling what? You don't have enough air. You don't have enough air. This is sensation of shortness of breath. And usually you should stop. And in this case, your dyspnea disappear. In this case, we talk about physiological dyspnea. Physiological dyspnea. But when we talk about patients, with cardiovascular or respiratory problems, the same may happen at rest. The same may happen in this case, we should talk about pathological dyspnea. Pathological dyspnea. Again, cardiac. No, it may be left ventricular failure. It may be mitral stenosis, heart valve disease. It may be pulmonary dyspnea due to obstructive lung disease, asthma, pulmonary embolism, pulmonary hypertension. It may be anxiety. It may be high altitude exposure. You know that we have so-called mountain disease. If you climb, actually, I don't know, Jamalungma or Everest, sooner or later you start feeling dyspnea. Why? But because just no enough oxygen. Anemia also may lead to dyspnea because we need circulation to transport oxygen, but oxygen transported by erythrocytes. If we have anemia, lack of hemoglobin erythrocytes, it also may cause dyspnea. Again, the problem of diagnosing, I told you, that the same signs may present or may happened in different disorders. And we should differentiate, we should understand which actually cause of dyspnea in this patient. What is the cause of dyspnea in this patient? And sometimes it's not so easy as it looks. We have classification of dyspnea. Usually we use so-called New York Heart Association functional and therapeutic. 4 grades of dyspnea. 4 grades of dyspnea. Now, grade 1, breathlessness. Grade 2, breathlessness on severe exertion. Grade 3, on mild exertion. And grade 4, at rest. Again, the worst case is grade 4, when patient experiences dyspnea even at rest. Grade 3, mild exertion. Grade 2, severe exertion. And grade 1, no breathlessness at all. But you may say, okay, on severe exertion, everyone experienced dyspnea. How to differentiate? No, again, simple example. You ask your patient, when you experience dyspnea? No patient tell you, you know, I live on 5th floor, and when I go to my flat on the 3rd floor, I start feeling dyspnea. I should stop and then move forward. But in the past, I was able just to reach my 5th floor without dyspnea. In this case, we are telling about what? Yes, in the past it was okay, but now he experienced dyspnea on severe exertion because I'm climbing 3rd, 4th floor. This is rather severe exertion. No, mild exertion, again, the patient just start doing something, in this case, dyspnea, and at rest, it's also clear. Sometimes we try to quantify somehow severity of dyspnea. Now, for example, patient has had 1 block dyspnea on exertion, DOEG, dyspnea on exertion, for the past 6 months. Before 6 months ago, the patient was able to walk 4 blocks without becoming short of breath. Able go actually without the dyspnea appear when patient 4 blocks. This is 4 blocks dyspnea. 1 block dyspnea. Well, this is typical for United States because they have specific positions of streets and avenues in their cities, and they talk about blocks. Now, in our country, as usually we live in many floors buildings, we may ask patients how many floors you can climb without dyspnea. And you can say about 2-floor dyspnea or 3-floor dyspnea, which floor actually a patient can reach without dyspnea or when dyspnea appear. No, this is just to understand what physical exertion may lead to development of dyspnea. What is the cause of dyspnea in case of cardiac problems? Usually, this is left ventricular failure causes dyspnea. Left ventricular failure causes dyspnea because of a rise of pressure in the left atrium and pulmonary capillaries, leading to interstitial and alveolar edema. This makes the lungs stiffness, less compliant, which increase the amount of respiratory efforts necessary to breathe, and usually fast breathing rates, tachypnoea, also present owing to stimulation of the pulmonary stretch receptors. Okay, I try to explain this easier. You know that most of the disorders, they affect left heart ventricle, we have right ventricle. We inject blood into big circle, into aorta. Right ventricle into pulmonary artery, into lungs, small circle. And of our left ventricle work harder because it should pump blood through the whole of our body, from feet to head to brain. And that's why if something happened with coronary arteries, with the heart, usually it causes damage of left ventricle. And usually dyspnea in cardiac problems. This is due to left ventricular failure. Something damaged our left ventricle tired, failed, can't eject blood normally. Result, if blood can't be ejected into big circle, what happened with this blood? Blood stay in small circle because right ventricle work proper way, eject blood into lungs, and left heart should do what? Accept this blood and move forward, eject forward. If left ventricle fail, we have congestion of blood in small circle. So blood stay in small circle in lungs, and pressure in lungs increase. We have increase of pressure, increased pressure in lungs. Result, high pressure force liquid part of blood plasma leave vessels and move to lungs, to interstitium of lungs. It's lead to the word. We talk about interstitial edema. Oxygen in this case, for oxygen, move alveoli to vessels, because what happened in lung, and this oxygen actually transported through the whole body. Is our breathing center get signals, something wrong with breathing. I can't oxygenate blood, lungs send signals. And our breathing center force lungs to move faster. The patient feel lack of oxygen, shortness of breath, and start breathing faster. That's why we may say that we have subjective dyspnea and objective dyspnea. What does it mean, subjective, objective? Subjective, patient feels something. Patient feels actually lack of oxygen. But in most of cases, we can see objective dyspnea, because objective dyspnea, this is tachypnoea. If patients feel lack of oxygen, what do you do when you are running? You start breathing faster. The same happens in patients. Objective sign of dyspnea, this is tachypnoea. This is tachypnoea. This is increase in actually chest movements, increase in chest, in the rate of chest movements. So again, remember that's why again main cause of cardiac dyspnea, this is left ventricular failure, and it's usually accompanied or presented with tachypnoea. There are specific types of dyspnea. Orthopnea is a form of breathlessness. The lying flat results in redistribution, leading to an increased central and pulmonary blood volume. So again, you should remember physiology and anatomy to understand what happens. Again, orthopnea, usually, before I told you that in case of cardiac problems, usually dyspnea happens when patients do something. Dyspnea on exertion. On exertion, dyspnea appear, at rest disappear. But orthopnea, this is something different. This is when dyspnea appear when patient lying flat. Usually it's happened at night. Patient wake up with severe dyspnea. How it's possible? Again, this is also result of left ventricular failure. But during daytime, patient in vertical position. As a result, some amount of blood stay in lower extremities, in the bottom of the body. That's why less blood return to the heart, and as a result, left ventricle should eject less amount of blood. Less amount of blood for left ventricle, easier to work. What happens at night when patient lie flat? His legs now horizontal, all blood return to central blood flow, and amount of blood which heart should can't, it failed. As a result, we have congestion of the have of orthopnea. Dyspnea happened when lying flat. No, we'll talk about this more carefully when we'll discuss heart actually problems, when we'll discuss heart failure. Actually, patients usually cope with orthopnea by propping themselves up with pillows. So how to avoid lying flat? You use pillows. And some patients with cardiac failure, they even sleep in half-sitting position. They use a lot of pillows to be not lying flat, but rise up his upper part of the body. Yeah. And that's why we may ask, how many pillows do you need in order to sleep? Of course, pillows may be different. We talk about something average. To help quantify the orthopnea, you can state, for example, 3 pillows orthopnea for the past 3 months. It means that to sleep, to avoid orthopnea, patients should use some 3 pillows. This is idea about orthopnea. Next type of dyspnea, this is paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea occurs when there is an accumulation of fluid in the lungs, pulmonary edema at night. The patient is waking from asleep, fighting for breath, dramatic and frightening experience. Actually, paroxysmal nocturnal dyspnea, similar if we talk about mechanism. Severe attack of breathlessness. Patient feel the patient feel that he can die even from such attack. In this case, we talk about paroxysmal nocturnal dyspnea, but actually this is severe. I may say that this is severe orthopnea. This is severe orthopnea. Nocturnal night, because patient actually at night time usually lie flat and sleep when lying flat. Sitting on the side of the bed or getting up may relieve this breathlessness if we talk about paroxysmal nocturnal dyspnea. Sometimes patients will get up and open windows to gasp for fresh air because they feel with no oxygen. No, wheezing due to bronchial endothelial edema is common. In this case, we talk about cardiac asthma. This attack of severe paroxysmal nocturnal dyspnea sometimes we refer as cardiac asthma. Sometimes patients present a cough with frothy or blood-tinged sputum. Why? Because this is pulmonary edema. Again, blood reach alveolus, and then patient coughing up this blood. And that's why we have such frothy or foamy sputum, pink color, because this is erythrocytes. No, initially these episodes terminate spontaneously recover without medical care, but in severe cases of pulmonary edema, patients need care because patients may just die due to heart failure, acute heart failure. Okay, next time, this syncope or fainting. This is loss of consciousness, that transient loss of consciousness. Transient loss of consciousness. That is due to inadequate cerebral perfusion. Ask patients what they mean by fainting or dizziness. Syncope may be related to cardiac as well as non-cardiac causes. It may be result of cardiac, non-cardiac causes. Of course, this is very serious and dangerous when patient lost consciousness. Patients afraid of this, but again, not in all cases. This is result of cardiac problems. You see how many possible causes of fainting may be. It may be cardiac, for example, decreased cerebral perfusion secondary to cardiac rhythm disturbances. It may be left ventricular output obstruction. It may be metabolic, like hypoxia, hypoglycemia. It may be psychiatric, like hysteria. It may be neurologic, like epilepsy or cerebrovascular disease. It may be orthostatic hypertension, maybe vasovagal hypertension. It may be even cough, even severe cough may cause appearance of fainting. Maybe carotid sinus cause fainting. Now let's discuss all possible causes of fainting. Again, questions you should ask. What were you doing? Again, the most important question. What were you doing just before you fainted? You had fainting spells or attacks. If so, how often do you have these attacks? Then abrupt onset of the fainting, so suddenly lost consciousness, so it was some progression. Did you lose consciousness? Because sometimes patients tell about loss of consciousness when they just fainted, when they just feel some dizziness, patient just sit down or lie down, but without real losing of, or without really loss of consciousness, without real fainting. Did you lose consciousness? In what position were you when you fainted? Was the fainting preceded by any other symptoms? For example, nausea, chest pain, palpitations, confusion, hunger. We try to understand what have happened, what caused this fainting. Did you have any worrying that you're going to faint? Sometimes patients feel beforehand, okay, I feel myself bad, I'm going to faint. Did you have any black terry bowel movements after the faint? What's the problem? Why we are talking about feces and fainting? But again, black and terry bowel movements, this is a result of internal bleeding. This is result of internal bleeding, and fainting may be due to anemia. The activity that precedes is important. Some cardiac causes are associated with syncope exercise. For example, valvular aortic stenosis, primary pulmonary hypertension, because again, if syncope happens after physical exertion, this is one case. We start thinking about possibility of some heart problems. If a patient describes palpitations before the syncope, arrhythmogenic cause may be present. Remember I told you about paroxysmal tachycardia when heart rate may be 160, 180, 200 beats per minute. Sometimes it leads to inadequate cardiac output that may lead to fainting. Attack of severe arrhythmia may lead to patient's loss of consciousness. Because cardiac output may be reduced by arrhythmias or obstructive lesions. The position of the patient just before fainting is important because this information may help determine the cause of the syncope. For example, if patient fainted after rising suddenly from bed in the middle of the night to run to answer the telephone, so-called orthostatic hypotension may be the cause. Orthostatic hypertension. Orthostatic hypertension is a common form of so-called post-ural syncope and is the result of peripheral autonomic limitations. Because when patient lying flat, blood pressure is very low. What for to pump blood with high force if patient lie flat and blood easily reach brain. But if you suddenly wake up and pressure, if this mechanism fails, patient may lose consciousness. Patient may lose consciousness. There is a sudden fall in systemic blood pressure resulting from a failure of adaptive reflexes to compensate for an erect posture. This is what I told you. Symptoms due to orthostatic hypertension include dizziness, blurring of vision, profound weakness, and syncope. Very important that many drugs can cause orthostatic hypertension by leading to changes in intravascular volume or tone. And the geriatric patients is most prone to orthostatic hypertension. Many people, elderly people, suffer from arterial hypertension, and we give remedies to decrease blood pressure. These remedies usually relax vessels, and in many cases, these don't let normal reflexes happen when patients wake up. And patients on medication sometimes presented with this paroxysmal nocturnal syncope. And that's why we should just explain our patients. Never do something very fast. If you wake up, okay, first, just lie 1-2 minutes in the bed. Then just slowly change your position into sitting position, and only after that, again, stay a few minutes. After that, you can stand up if you feel yourself okay. Just do everything slowly, and you can avoid this paroxysmal nocturnal syncope. Mixed urination syncope usually occurs in men during straining with nocturnal urination. Usually at night, patients sometimes go to urinate, and sometimes it leads to fainting. May occur after, for example, considerable alcohol consumption. No, this is also something wrong with reflexes. Very interesting, vasovagal syncope. Very interesting, vasovagal syncope. Vasovagal syncope is the most common type of fainting and is one of the most difficult to manage. It has been estimated that 40% of all syncopal events are vasovagal in nature. Vasovagal syncope occurs during periods of sudden, stressful, or painful experiences, such as receiving bad news, surgical manipulations, trauma, loss of blood, or even the sight of blood. You know that it's happened. No, even I remember when I was a student and first time our group enter surgical or operation room where surgeons performed some surgery. One of my friends lost consciousness because he saw a lot of blood, he saw open wounds, the open patient's abdomen. Result was a vasovagal syncope, losing of consciousness. And doctor told, and what I should do to help this guy or to help the patient on the surgery. That's why I remember another student. What was the problem? The problem was how to take his blood sample during actually blood. We did just collect his blood in lying position. Ask him to lie flat on the bed, and only in such position nurse was able to take blood. So again, or sometimes you hear some bad news and may lose consciousness. All this vasovagal syncope. This is not due to problems with heart. This is not problems with heart output. This is actually due to disbalance. Our severe stress may cause relaxation of vessels, blood pressure drops, and patient lost consciousness. In all such cases, we talk about vasovagal syncope. Vasovagal syncope. It's often preceded by pallor, nausea, weakness, blurred vision, lightheadedness, perspiration, yawing, diaphoresis, hyperventilation, epigastric discomfort, or sinking feeling. Patient feel that he is sinking. There is a sudden fall in systemic vascular resistance without compensatory increase in cardiac output as a result of increased vagotonia. That's why it's called, that nervus vagus causes relaxation of vessels, nervus vagus. That's why it's called vasovagal syncope. If the patient sits or lies down promptly, frank syncope can be aborted. That's why in such cases, if you know that this patient experiencing just, it feels something wrong, just sit down immediately or lie down, and you avoid the actually real syncope. one hand, this is rather benign condition because when patient fall down, his posture becomes horizontal. In this posture, blood easily reach brain. All compensatory mechanisms switched on. Suprarenal release epinephrine, and actually blood pressure restored. Actually, and patient recover. But only one problem: when patient fall, he may damage his head. Sometimes it may lead to very severe trauma. Falling down, patient can beat his head, and actually it may lead theoretically even to patient death, not due to syncope, but due to trauma, which may be caused by such kind of falling down. And you should know first aid in case of vasovagal syncope. Actually, first aid is very simple. Sometimes, if you see someone who fall down, what people try to do, they try to help this patient to be in sitting position or even standing position. It's wrong. Never try to actually help patient immediately to stand up, because his blood pressure may be still very low. Okay, some people start doing what? Shaking, sometimes beating his face, or cold water applied, trying to actually force this. Actually, remember this: only one very simple maneuver, or only one very simple inside this. This is falling. Just raise patient's legs. Again, patient should be in lying position, lying flat, and just raise his legs. What for? Because blood from legs go down, reach brain, and the result, patient recover. No, it shouldn't be 90 degrees. Just raise patient's legs and put some bag onto legs, to let blood go down and reach heart and reach brain. This is only one proper way how to help patient in vasovagal syncope. Of course, before you do this, you must be sure that this is just vasovagal syncope, because patient may lose consciousness due to heart arrest. And in this case, you need to do resuscitation, RCT, CPR, cardiopulmonary resuscitations. That's why check patient's heart activity, check patient's breathing. But one thing, usually when we check patient's heart activity, we use peripheral pulse. In case of syncope, you find nothing because pressure is low and peripheral pulse absent. You should check heartbeats where? Pulsation of carotid artery, or you can use phanendoscope to check heartbeats. Because if it's just fainting, heartbeat carotid sinus syncope. Carotid sinus syncope associated with hypertensive carotid sinus and hypersensitive carotid sinus. Hypersensitive carotid sinus, and it's seen more commonly in age population. On the neck, we have arteria carotis, remember anatomy. And if you remember anatomy, we have some dilatation of arteria carotis, known as carotid sinus, The fact is that this place our body uses to measure blood pressure. Now, this is site where we have special receptors to measure blood pressure. And this measurement happens, and our brain know how high is blood pressure and what to do: decrease blood pressure or increase blood pressure. And that's why what may happen if you press this site, if you press carotid sinus, pressure increase here, and our brain believe that blood pressure too high. Do what? Let's relax vessels to decrease blood pressure. but really blood pressure was normal. It's just pressure on the neck. It's just pressure on carotid sinus. But if vessels relaxed, it may cause drop of blood pressure, blood from brain goes down and patient faints, lost consciousness. That's why all situations or conditions when we press carotid sinus may cause fainting. If you check pulse on the neck, never press hard and never do actually when it may happen. No, for example, just tight, very tight shit, yeah? T-shirt or shirt, or very tight tie. The patient use very tight tie. It's also may induce pressure on the neck and induce carotid sinus syncope. Yeah? No, actually, two types of carotid sinus syncope. For example, cardioinhibitory when we have bradycardia, vasodepressor when we have low blood pressure without bradycardia. But for patient, there's not a big difference. Why he faints? And that's why, you know, in the office, some people prefer to carry special official dress with very tight shirt with tie. Again, sometimes it's not good because if it's cause pressure on the neck, it may cause actually bad feeling and even sometimes faint. Post-tussive syncope. Post-tussive syncope generally occurs in patients with chronic obstructive lung disease. No, it's clear. After severe coughing, patient may lose consciousness. No, several mechanisms have been postulated to explain its occurrence. Season in thoracic pressure, which depresses venous return. And there may also be rising cerebrospinal fluid pressure, producing increased return to the brain. So again, you see, you studied physiology, you studied anatomy, just to be able to understand what I explained to you. Again, I'll try to do it more easily. When you are coughing, how you are coughing? You inhale the air, and to cough out, you increase pressure in your chest. If you increase pressure in your chest, for blood is more difficult to reach the heart, to reach the chest, because already this is pressure inside chest. As a result, cardiac return decrease. If cardiac return decrease, less amount of blood may be ejected. Less blood ejected, again, brain experience shortness of oxygen and patient may faint. No, this is such kind of actual interpretation why it may happen. Okay, you see how many types of dyspnea may be, how many types of dyspnea may be, how many types of syncope may be. And you should differentiate because, again, different types need different treatment. Next sign, fatigue or weakness. No, fatigue, common symptom of decreased cardiac output. Fatigue, who is fatigue? Who never experienced weakness? You may say, okay, and I experience severe fatigue, I can do nothing, I don't want to go to the university, I'm in fatigue. But in cardiac patients, fatigue may be the first sign. You know, I told you that actually it's very important to detect disease on early stage. But problem is that on early stage, usually number of signs of symptoms are very low or sometimes even absent. And you know, in case of cardiac failure, severe heart problem, first symptom, maybe not syncope, not dyspnea, not dependent edema, maybe just fatigue, unexplainable. Patients feel that he can't work normally, he can't do the same physical activity than it was. That patient becomes weak. Patients become weak. And if patient asks for care, you know what you can say? Okay, you're weak because you are too tired. Have a rest and everything will be okay. Don't do this. Because again, fatigue may be first sign or symptom of cardiac vascular problems, of heart failure, low cardiac output. Then patients with congestive heart failure, mitral valve disease frequently complain of fatigue. Fatigue, however, is not specific for cardiac problems again. It's not specific. The most causes of fatigue, anxiety, depression. You know that depression is #1 disease in the United States. I don't know why all of them are depressed. For example, I have no time to be depressed. Such is a rare problem, may happen in hardly work people because they don't have time for the rest. But nevertheless, again, fatigue may be presentation of depression. Yes, depression is a problem, but it's not so severe as heart failure. No, other conditions associated with fatigue include anemia, chronic disorders like, I don't know, chronic hepatitis, liver disease. But first sign, maybe also fatigue. Anemia, blood disease, also fatigue. And again, fatigue may tell us about many disorders, but you should differentiate and to understand what have happened. Why patient in fatigue? It's just depression or severe disease of inner organs, like heart failure. Again, questions. How long have you been tired? Was the onset abrupt? Do you feel tired all day in the morning or in the evening? When do you feel least tired? Do you feel more tired at home than at work? Is it fatigue relieved by rest? You know, for depression, for psychological problems, typical that patient experience more fatigue at rest at home than at work. How it's possible? Because when you are working, you have no time to think about fatigue something. But when you're at home, you feel that you have no strength, you are fatigued. In case of cardiac problems, it's not so, it's vice versa. Fatigue happened during activity, during exertions, and at rest it's disappear. Again, this is difference between emotional or psychiatric fatigue and real fatigue. Okay, next sign, dependedema. No, actually, you know, I told you, more severe disease, more severe stage of disease, more signs and symptoms. And severe stage of disease, easier to detect than early stage of disease. And dependent edema, this is sign of severe cardiac failure. Dependent edema, this is sign of severe cardiac failure. Severe cardiac failure. What is it? This is swelling of the legs. Appear usually, again, on patients' feet. Then this edema, I may say, rise down. The more severe condition, higher level of this edema. No, swelling of the legs, form of dependent edema, frequent complaint of patients. Heart failure results in salt and water retention and retained formulate in the feet and ankles of ambulant patients and over the sacrum of bed-bound patients. The edema associated with heart failure becomes progressively worse during the day, and it's often absent on initial rising as the fluid is reabsorbed on lying down. When severe, the cough and the thigh may become edematous, thigh may become edematous, and associated and ascites of pleural effusion may develop. Okay, let me try. Remember, I told you, heart failure lead to congestion of blood. So blood should be pumped, blood should circulate. by contraction of ventricles. If heart fail, if left ventricle fail, we have congestion of heart, blood in lungs. But usually after failure of left ventricle, patient experience failure of right ventricle. What does it mean, right ventricle failure? It means that right ventricle can't pump blood forward. But if it can't pump blood forward, it can't collect blood from big circle. And as a result, congestion of blood in big circle. And where is big circle? This is all our body, including hands, legs, head, abdomen. This is all big circle. What happened then? When patient in vertical position during daytime, he's moving, he's doing something, working, blood in his lower extremities congest. We use term congestion of blood happen, because blood can't easily be removed by normal circulation from legs, and it means that blood stay in lower extremities for a long time, and as a result, pressure in vessels of lower extremities increase. We have increase in pressure in lower extremities. Result: if pressure increase, water, liquid part of blood, just leave vessels and move to surrounding tissues. Which surrounding tissues? No, we have tissues as we have skin. Under skin, we have some. You can see in this case. Edema. What is edema? Edema fluid. Some just at evening, his shoes becomes too tight. Why shoes becomes too tight? Because legs or feet becomes edematous, enlarged due to edema. This is explanation to characteristics of this edema. First of all, site, where it's appear. First, it's appear on legs, on feet. Second, when it's more advanced, in the morning or in the evening? In the evening. Because at night time, when patient lie flat, water removed from legs, because when lying flat, blood easier to circulate, easy to pump blood when you are lying flat. And that's why during night time, usually edema disappear at first time. In the morning, no edema. But during daytime, edema appear, and at the evening, it becomes more advanced. Second, actually, characteristic. First characteristic, localization, legs or feet. Second characteristic, that it becomes more advanced in the evening, and in the morning may disappear. Third definition, cold edema. If you put your palm, you feel cold. Why? Poor circulation. Poor circulation, temperature decrease, and you feel cold. And also this edema, known as pitting edema, pits, the excavations, pitting edema. Why we call this so? If you press site of edema and you see excavation, you see pits. That's why it's known also as pitting edema. Why? Because edematous tissues create some excavations, and excavation can't escape, can't disappear immediately. That's why I'm talking about pitting edema. Also use the same term to describe edema due to cardiac problems. When condition becomes worse, when heart failure becomes worse, the level of fluid accumulation increases, and in severe stage, this fluid, due to the same mechanism of congestion, may appear in abdominal cavity. We talk about ascites. May appear in pleural cavity. We talk about pleural effusion. No, this is severe stage of cardiac failure. Questions. When was the swelling first noted? When it first appeared? Are both legs swollen equally? Did the swelling appear suddenly? You know, another tip for characteristic for this edema, usually this is symmetric, the two legs effect. Because if you see one leg normal, second leg Edematose, no, it's rarely happens in cardiac edema. It means that something local problem happened. For example, problems with lymph drainage, the removal of lymph from this leg. That's why, again, don't forget that usually this edema actually symmetrical. That's why we are talking both legs swollen equally. Are both legs swollen equally or not? Did the swelling appear suddenly? Again, cardiac edema usually this is something different. For example, when blood can't go out due to thrombosis. Is swelling worse at any time of the day? Again, I told you about worsening at the evening. Does it appears after night? Does it disappear after night sleep? Again, in cardiac case, it's disappear after night sleep. Does elevation of your feet reduce swelling? It's also essential because sometimes even patients, they use some pillows to put on the feet. That in this position, blood easier removed and water easier removed from legs. What kind of medications are you taking? Is there a history of kidney, heart, or liver disease? Why we're asking about kidney, heart, or liver disease? Because kidney disorders also may cause this edema. Liver diseases also may cause edema. That's why we're asking about previous disorders. Do you have shortness of breath? Why we ask about shortness of breath? Because actually, in case of edema, because shortness of breath or dyspnea, this is another sign of cardiac failure. And in most of patients with edema, which happened already, they also have dyspnea because edema, this is severe stage of cardiac failure. And if edema detected, dyspnea detected or presented in all cases. Do you have pain in the legs? You know, usually in cardiac edema, no pain. If pain happens and then edema, this is something acute. Again, for example, deep veins obstruction. Patients with congestive heart failure, lower extremities that worsens as day progresses. It's least in the morning after sleeping with elevation of the legs in bed. If patients also complain of dyspnea, it's helpful to determine which symptom comes first. In patients with dyspnea and edema, secondary to cardiac causes, dyspnea usually precedes the edema. I told you that dyspnea is a sign of cardiac failure and it usually appears first. Edema, this is already a sign of terminal, severe stage of cardiac failure. And usually first we have dyspnea and after that we have edema. If patient lie flat and can't stand up, in this case, where water accumulated in the lower part of the body, somewhere in sacral area, this is already terminal stage of patient disease. And final sign we should discuss, this is hemoptysis. Hemoptysis, this is presence of blood in sputum. From one side, of course, it's first what we are thinking about lung disorders, tuberculosis, abscess, lung cancer. This usually leads to appearance of blood in sputum. But in addition to the pulmonary causes, mitral stenosis, this is heart disease, should not be forgotten as the important cause of hemoptysis. Why? Because actually this type of heart valve lesion lead to very high pressure in lungs. Very high pressure in lungs, arterial pressure in lungs cause rupture of small vessels. As a result, we have the patient coughing up this blood. That's about hemoptysis as a presentation of heart disease, for example, okay, that's all about complaints in case of cardiovascular disorders. You see, number of such complaints is not enormous, but how many questions you should ask to understand, to describe each complaint, because each definition, each characteristic can give you ideas. Is it cardiac or pulmonary? Is it actually which type of cardiac problems patients suffer from? And this is very big challenge, diagnosing, differential diagnosing. Okay, do you have any questions?
No, sir.
No,
No,
sir.
sir.
No,
Okay,
sir.
if no
No,
question,
sir.
actually our next lecture will be next week. So see you next lecture. Bye.
Thank you, sir.
Thank you, sir.